Good afternoon, everyone. I would like to thank the organizing committee sincerely for the kind invitation to participate in this session. My talk is going to involve a few debatable issues in pediatric glaucoma. So we'll be discussing the issue of IOP only based therapeutic decisions, timing of surgery for congenital glaucoma, syndromes of coexistent congenital glaucoma and cataract, and a glimpse about the surgery techniques, whether segmental or circumferential angle procedures, as we've heard from our dear Professor Adil Laih. Now, the first issue, diagnostic issues, IOP only based therapeutic decisions. What is meant by this question is, what is the weight of the intraocular pressure in pediatric glaucoma diagnosis? That is, should we make therapeutic decisions based mainly and only on the intraocular pressure? The Childhood Glaucoma Research Network, as Professor Alay has just demonstrated to us, has put forth several diagnostic criteria for childhood glaucoma. Intraocular pressure is the first criterion from them, very true, but there are other 5 additional criteria without longitudinal follow-up and 3 additional criteria with longitudinal follow-up. What about the issue of the elevated intraocular pressure? There are several issues related to the measurement of the intraocular pressure in children, as Professor Alay has just hinted to. The circumstances of measurement, the local conditions of the eye, the normal reference, the type of the tonometer that is used, whether the examination was done for a conscious child in the office or was it conducted under general anesthesia, was the exposure of the cornea adequate, was the cornea healthy, is there a normal for the age group, is there an age-adjusted normal, the depth of the anesthetic, the type of the anesthesia used, is it inhalational or is it ketamine, the cornea, is it scarred, is it clear, is it edematous? All these factors cast doubt about the accuracy of measurement of the intraocular pressure in children. So the conclusion or the recommendation is that diagnostic and therapeutic decisions must be based on multiple parameters, as is recommended by the World Glaucoma Association: the condition of the optic nerve, the cup-disc ratio asymmetry, focal thinning, the condition of the cornea, the status of the axial length of the eye, and most importantly, the change over time of these parameters. Based on all these multiple parameters, the diagnosis is to be made, not only the intraocular pressure. The next debatable issue is the timing of the surgery for congenital glaucoma. How early should we operate? This is a QR code for a link for an article that I've published in 2017 about the early versus late surgery for childhood glaucoma. It's a short article, it's a 2-minute read only. Let me summarize it to you here. The very early surgery, the issues with it are the diagnosis is not always clear because it is difficult to measure the intraocular pressure accurately in very young children. Cloudy corneas may be caused by conditions other than elevated intraocular pressure. So a hasty decision to operate does not allow the surgeon to judge whether the disease is progressive in nature or stationary. The operative procedure is technically difficult because the palpebral fissure is very narrow, and the filtration surgery, as Professor Lay has just hinted, has a very poor prognosis. Whereas a delay of around 2 months would not cause a significant visual deterioration in the optic nerve and the cornea. It gives time for the palpebral fissure to grow, making the intraocular pressure measurement more accurate and the surgery easier to perform. If the cornea was cloudy from conditions other than elevated intraocular pressure, it would be given chance to clear, and the healing response is definitely better. And generally speaking, for neonatal childhood glaucoma, the success rates are so poor, in the order of around 50%. So the surgeon's dilemma is a very early surgery to perform a hasty, technically very difficult operation with an extremely low chance of success with a potentially doubtful diagnosis, or to wait for around a 60-day delay that brings with it a solid diagnosis of glaucoma, makes the procedure technically easier to perform with a higher success rate, and allows the eventual reversal of almost all pathological changes induced by the disease. In my personal belief, this informed timely delay of around 2 months or 60 days would be more beneficial to the child, and this is our current practice, at least for this year. The next debatable issue to discuss is the syndrome of coexistent congenital cataract and glaucoma. There are certain syndromes in which congenital cataract and glaucoma coexist. So, do the surgeons operate the cataract surgery first? The pros of this are that there will be no surgery performed after the glaucoma surgery, and hence no compromise of the glaucoma filter. The cons are definitely poor visualization in the presence of an edematous cornea, and this will delay the glaucoma surgery, and the glaucoma surgery would be difficult in a vitrectomized eye, as anterior vitrectomy is an inherent part of congenital cataract surgery. But what about glaucoma surgery first? The pros are a clear media that will be provided by lowering of the intraocular pressure, which makes subsequent cataract surgery easier. The glaucoma surgery is easier to perform on a formed globe with native vitreous in it. Glaucoma surgery will be done early enough, but the cons are that the subsequent cataract surgery will compromise intraocular pressure control if a filtering procedure is performed for the glaucoma. What about combined or simultaneous cataract and glaucoma surgery in one setting? The extensive manipulation results in severe postoperative inflammation, and the endpoints for either surgeries are paradoxical. For the cataract surgery, the endpoint is a pressurized globe at the conclusion of the surgery, whereas for a glaucoma surgery, a leaky wound is the prerequisite at the end of the surgery. And this might result in vitreous clogging of the glaucoma surgery, both the angle and the filter. So the conclusion or the recommendation is, for a combined procedure, definitely no. For sequential procedures, there remains for the literature or the studies to prove which initial surgery would be better, and this is open for a vote by the audience. The final debate that is there is for the pediatric glaucoma angle procedures, whether to perform a segmental or a circumferential procedure. For segmental procedures, the pros are that it stood the test of time. It is generally more physiological because the body has more reserves than its actual requirements. That is, we know that not all of the 360 degrees of the circumference of the angle are actually required for a normal intraocular pressure, and definitely segmental angle surgery is technically easier than circumferential angle surgery. Whereas the pros of a circumferential angle surgery is that it allows wider access of the aqueous humor to Schlemm's canal and results in lower intraocular pressure reduction, but the problem is it is technically more demanding. So, my take-home message are that there are numerous diagnostic and therapeutic issues in childhood glaucoma that are still unsolved and remain a matter of debate. Individualized approach is mandatory for the optimal outcome. There is no one-size-fits-all for childhood glaucoma, as in all branches of medicine, of course. Issues so far raised includes that the diagnosis is based on not only on the intraocular pressure, but in addition to other features with it. A timely informed delay of surgery for childhood glaucoma to the second month of life is worth consideration and discussion on counseling with the care providers. Approach to congenital cloudy cornea with possible glaucoma needs considerable thinking, and consider glaucoma surgery first in syndromes of coexistent congenital cataract and glaucoma. And for the surgical techniques, segmental versus circumferential angle surgery, the decision has to be individualized for every patient. And thank you very much.
شكرا دكتور نادر.